Welcome to The Hill's Coronavirus Report. I'm Steve Clemons, editor-at-large of The Hill. Each day we are interviewing consequential leaders and innovators in the battle against the coronavirus. COVID-19 continues spreading across the United States as the country reopens. Some states have seen declines in case numbers, while others have seen spikes in their cases. The Midwest in particular has continued to have persistent outbreaks. There are ongoing trials for vaccines and other treatments, but it remains unclear when those might be ready. Some health experts have said potentially by the end of this year, but others have warned it could take much longer. Joining me now is senior scholar with Johns Hopkins Center for Health Security and associate professor for the Department of Environmental Health and Engineering and Department of Epidemiology with Johns Hopkins Bloomberg School of Public Health. Welcome, Jennifer. That's a lot of responsibility you have. I just want to tell the audience that you and I and Lena Wen, the former Commissioner for Health for the City of Baltimore, did a program in the U.S. Congress for the U.S. Asia Foundation before this had really taken hold. It was on the very front end. And I don't think I heard a more stark, not necessarily prediction, but warning about what we might have to do. And when I think back to who had it right, it's you. And so the first question I have is, how did we get here, given the fact that people like you were forewarning of such dark days?
Yeah, it's been really an unfortunate road that we've been on. I mean, I think anyone who has studied pandemics and these sort of viruses, once we knew in January that this virus was capable of sustained human-to-human spread, that meant that we were on the path to a pandemic. And so, many of us, lots of us, talked about the need to urgently prepare. But unfortunately, there wasn't a lot of action that happened in January and February. And I think where we found ourselves mid-March, where we were looking down at rapidly accelerating case numbers and worried that we were headed for health system collapse like we were seeing in other countries, that really kind of put us into a position where there was no choice but to implement these very broad and frankly, damaging in their own right, but nonetheless necessary lockdown and all sorts of other restrictions and an attempt to kind of hit pause and make up for lost preparations.
If you were called back to Congress to testify at some point for some commission that looked back on this, what do you think the points of dysfunction were that mattered most in getting us to where we are today?
There are a few things. I mean, one, obviously, the inability to more broadly test for the virus that causes COVID-19. I mean, we constrained for a very, very long time, far too long, who could get tested for it. So for months, even after this virus was circulating in many countries across the planet, you could only be tested if you had traveled from Wuhan. We had also shut down travel from Wuhan, so essentially that left no one to test. Nonetheless, we didn't expand testing at that point. And so what that meant was that the virus could enter the country. It was already there. It was circulating, but we couldn't see it. And that really made us lose ground. One, because we want to find where the infections are so that we can isolate those people, prevent them from spreading their infection to others, prevent the case numbers from growing and taking a real foothold. Other countries that acted early were able to keep their case numbers low, but we never did that. But beyond just the testing, the laboratory issues that we had, and it wasn't all the same. I mean, there were laboratory issues. We couldn't get the test kits out to the state public health labs, and that was a problem. But aside from that, there were other places that could have done testing. We should have fixed that. We basically put all of our eggs in one basket, which was to ban travel, which, may sound like a good idea. It seems, it probably sounds reasonable that if the virus is somewhere else, you don't want it to come here. And so that the way to do that is to stop people from traveling from those places. The problem was we actually didn't know where the virus was because many countries weren't yet testing. And we only banned travel from a few places because logistically it would be impossible to support the travel bans had we expanded it. And so that put all of our eggs in one basket. And in my view, I think it psychologically reinforced this idea that the virus was a problem across the globe and not necessarily a problem that was already likely circulating in the US. I think that's one of the reasons why we lost time preparing, thinking about how we were going to isolate sick people, thinking about how we were going to expand capacities in hospitals, thinking about how we were going to protect nursing homes and other vulnerable groups. So it's really unfortunate, but I hope that, now that we've had this pause button that the restrictions have enabled, that, it's that we've been using this time to try to make up for lost ground.
Now, Jennifer, we know that nursing homes, elder care facilities are a big target. Another target, I talked to Jerome Adams, the Surgeon General of the United States last week about this, and And he continued to highlight what he's been highlighting, which is that communities of color, communities in the lower socioeconomic area are vulnerable communities, and they have not had the level of decades-on health investment and ecosystem investment that other communities have. And so they have an underlying condition generically, but they have lots of health underlying conditions. I'm interested in whether or not you agree with the Surgeon General, and what do you think we need to do as a nation to address the disproportionate way that coronavirus is hitting those communities?
Yeah, it's very clear from both the case numbers and the hospitalization data and the death data, unfortunately, that communities of color are being overrepresented and really harder hit than many of us, which is really just a very, very unfortunate situation. I think there are a number of factors that contribute to this. I mean, clearly underlying health conditions are an issue. We also know that those underlying health conditions don't occur in a vacuum. They are also associated with socioeconomic status and income, and the ability to obtain healthy foods can be associated with a lack of ability with certain chronic conditions. So there are deeply entrenched disparities that contribute to this. But also, the main way that we have been protecting ourselves in these months is, telling people stay home as much as possible, telework if you can. And that is not something that's available to all people. Not everybody has the luxury of being able to stay home. Many people are service workers and have to go out because they're essential, but also they need a paycheck to support their families. And so being able to stay home, frankly, is a luxury, and it's not one that's available to everybody. So there are lots of different ways. We're also hearing about disparities in accessing care, particularly accessing testing for COVID-19. There's been some great reporting lately suggesting that testing sites tend not to occur in some of the harder hit areas because, if we rely on chains, they may not have stores in certain neighborhoods. And so access issues are huge. If people aren't able to be tested early and they're not able to seek care, when they need it, that obviously can worsen their outcomes, and unfortunately with deadly consequences. So all of the injustices and inequities that exist in our society, I think, are playing out in the case numbers.
Jennifer, you're a scientist. You live in the world of science and empiricism and experiments and data and looking at all of that. And I haven't asked this of anyone, how's the morale of the average person in the world of science today, given some of the disregard for science that we've seen in some quarters in Washington?
Yeah, I think, first of all, anyone who has any knowledge about COVID-19, and that's a large part of my academic community, I think a lot of us have something to contribute. We're all pretty exhausted, mostly because we feel an urgency to contribute, and in our world, it's contributing what we know, and there's just a lot of need for information right now. So most people have been basically working around the clock, trying to make the situation better best we can. Obviously, there is a deep disappointment that we got to this point, particularly for those who have been involved in the preparedness community and sounding the alarm for decades. There's a deep disappointment that we turned out to be right on many issues. We sort of hope that these things never happen, but we very much know that they can. But, at the end of the day, those of us in the science community, and particularly those who are busy and right now, are luckier than most. Many of us are not on the front lines. We're not the ones putting our lives and families at risk, and we are employed and still getting a paycheck. So I personally consider myself lucky. My kids are at home. I've got 2 young kids that we're trying to homeschool at home. It's really, really difficult, and my kids are suffering. But as a family, I would say we are luckier than most. We breathe every day, and we're safe.
One of the things that occurred to me is last week, Larry Kramer, a gay anti-HIV AIDS activist who used to pester, which is a polite way of saying it, Tony Fauci early on in the days, to come up with a solution to AIDS faster, and to talk about this as being a plague. So Larry Kramer was an icon to many people and said he bent the curve in terms of what was possible in terms of vaccines, dealing with people, and destigmatizing at that moment this. And so I'm interested in your insights on whether, when you look back at that, I don't know whether we have stigma issues out there, but I see some people not reporting that they've had COVID until much later in fear of the consequences of that. But are stigma an issue? Are we having problems with getting the resources in the right place for vaccines? Do we need a Larry Kramer today?
Well, first of all, I think we always need a Larry Kramer. I mean, the more that people feel an ownership of this issue and realize that when we're talking about public health, we're talking about them, the more the public is in public health, the better. And I think really engage and energize populace is the pathway to public health protection. I think a number of countries that have done really well in responding to this, one of the things that I've noticed is that they have data that's highly available and completely transparent so that people can see what's going on and know what's going on and make decisions for their families and hold the authorities to the appropriate standards. So I think an energized and engaged populace who feels that this is important to them and take interest in it is always important. On the topic of stigma, this is a hallmark of infectious disease outbreaks. This almost always happens. I'm not a social scientist, but I have a good colleague, Dr. Monica Shaksbana, who's a cultural anthropologist who studies this very topic on stigma. And what she has taught me in her decades of looking at this is that, often when we have these scary and seemingly unexplainable events happen to us, as communities, we look for someone to blame. And unfortunately, we can always find someone to point a finger at. And so that is one of the things that contributes to stigma. There's always a perceived cause of the disease, even though the cause is really the virus and not a person. But that stigma is out there and it has enormous consequences, including, and we've already heard this, there's been some reporting now about people not wanting to be tested that have symptoms of COVID-19 because they don't want to be identified as such. They may not seek care if they are experiencing worsening of symptoms because, they're sort of afraid of being known. And this can have enormous consequences. One of the things I'm deeply worried about is some reporting that happened over the weekend out of Minnesota, where law enforcement in commenting on the protest talked about conducting contact tracing on the people who had been arrested, which is an extraordinarily unfortunate phrase to use because contact tracing is a real public health tool that we will need to depend on in order to control COVID-19. What it means in a public health context is when we find a case, we try to figure out who that case may have exposed in the time in which he or she was contagious, but possibly didn't know that he or she was infected. And then we go and try to find those people and tell them that they were likely exposed to COVID-19 and that it's in everyone's best interest if they stay at home until we know for sure that they're not sick. When public health does this, it is not a law enforcement action. It is something that we do to help people. Nonetheless, when law enforcement appropriates that term for their very different activities, I worry that it can have deep consequences and it will drive cases underground. And I fear that it will make people fearful not only of being diagnosed, but also potentially participating in real public health beneficial contact tracing activities.
In our last minute or so, Jennifer, I'd love to get your thoughts on something Dr. Robert Redfield said on this report recently, in which he said, look, we're going to find people who are homeless and who have no resources, who may have COVID or have been exposed to COVID. We're going to have to provide them shelter. We're going to have to look at them as fully included in this diagram, that you cannot afford to allow, until we have therapies and vaccines and treatment, we cannot afford to have anyone left out of the net, if you will. And you've talked a bit about needing an insurance in this and looking at how you cover all these communities. In our last minute, so tell us a little bit about what you think we need that we don't have in place today.
Yeah, so the insurance issue is really important. We're hearing a lot of reports of people being hit with very large treatment bills. So when all of the kind of action on the Hill happened, one of the first things they did was to make sure that people could be tested for COVID-19 for free, or at least not have the fear of costs prevent them from being tested. I think that those actions largely, but probably not completely, solved the problem. But what was not included in that was assurances that people's cost of treatment would be covered. And some colleagues and I wrote an op-ed, a few months ago, basically calling for a public health crisis insurance that would not only ensure that everybody had full coverage, but also that could capture data on who was being treated and what their risk factors were and what their outcomes are, because we're still trying to learn about this virus and doing so with very imperfect data systems. One of the things that we've been doing at Johns Hopkins is tracking COVID-19, and most recently stood up an effort called the Testing Insights Initiative, trying to understand who's getting tested and who's not, and how testing compares between states, because there's no other way to interpret the case numbers. We need better data. And the extent to which we are systematically omitting people from our data capture systems because testing is not available in their neighborhood, or people are sort of off the grid, if you will, persons experiencing homelessness, it's a big problem. But nonetheless, we are not going to be safe unless everybody is taken care of. We saw this in other outbreaks just before COVID-19. There are enormous outbreaks of hepatitis A occurring across the U.S., in large part in persons experiencing homelessness. One of the issues is they very much rely on private businesses as places to wash up and use the restroom, and all those places are closed in many communities. So I can imagine there's going to be huge tolls unless health authorities and social service organizations are able to have a COVID response plan in the communities of persons experiencing homelessness.
Well, Jennifer Nuzzo from the Johns Hopkins Center for Health Security, thank you so much for joining us today. And I want to thank all of you for joining me. We're going to see you tomorrow. I'm Steve Clemons. Be well and stay safe.